I'm Kelsey Louie. I'm the Chief Program Officer of Harlem United, and today I'm going to talk about how you can use data to help your agency or programs have some programmatic opportunities to improve women's health, to evaluate a new model, to improve nature of referrals and even staff efficiency, and to improve rent collections. So a little bit about Harlem United. Harlem United is originally an AIDS service organization. However, we're expanding our mission to serve the general homeless population. All of our services are centered around a provider-led, patient-centered primary care and dental practice. We're also an FQHC, a federally qualified health center. And we currently exist in two divisions, services for people with HIV and AIDS and services for the rest of the community. Under HIV services, we have something called the Adult Day Health Centers. Food and nutrition services, all of our housing programs are for people with HIV. We have Cobra Case Management, which is now Health Homes. On the other side, we have harm reduction services, Black Men's Initiative, which includes integrated interventions for MSM of color, as well as access to care and services to help connect people to primary care. In our housing programs, we have every permutation of housing that you can imagine in supportive housing. We have permanent, transitional, congregate, and scattered site housing. In our housing programs, we have a number of programs for the generic population for people with HIV and AIDS. We also have some specific programming for women with children, women with mental illness, New York 3 housing for people who are chronically homeless, as well as dually diagnosed with substance use and or mental illness and HIV/AIDS. We have 2 emergency congregate sites, as well as 2 permanent congregate sites. Over the years, we've seen unparalleled growth in AIDS housing. In 2011, we achieved 586 units of housing, and part of the way that we've done this is through the use of data. So I'll talk about some of the programmatic opportunities that Harlem United has been able to achieve by using some information and data. So some of this may be intuitive, some may be less so. So one of the findings that we had was over time, people living with HIV and AIDS often experience a decline in cognitive functioning. So in response to that, we offered more skills-based training for clients. We trained staff how to handle cognitive delays. We also assess clients for cognitive impairment, and probably the most important thing is that we reframed non-compliance. So if a client forgets an appointment, what are the things that we assume? Maybe they're using drugs, maybe they just forgot, maybe they didn't care, maybe they're resistant, but maybe there's just some cognitive functioning that didn't allow them to make that appointment. The second finding we found was there was a high incidence of hostility and aggression compared to depression among our housing clients. And so in response to that, we provided more coping skills building, more anger management groups, and some clinical training geared towards de-escalation. For those clinicians out there, you can tell that hostility, aggression, and depression may manifest in the same way, but really to be able to treat the right symptom, you really need to look at what's causing the behavior. Third, the most significant difference between clients with declining health and those whose health were not declining was current substance use. So in response to that, we partnered with other parts of the agency to provide a full continuum of substance use and harm reduction services. We also provided more treatment adherence work, and we looked to hire more staff with backgrounds in substance use and harm reduction. And finally, in terms of programmatic opportunities, we also found some research that said that a woman's treatment adherence to HIV medication decreases approximately 9% with each child that she has. We actually believe that that number grows not linearly, but exponentially. So in response to that, we provided more parenting skills training, some parent-child interaction training, coping skills training, pro-social skills development for the children, and more family counseling. So speaking of women's health, with these findings and use of data and our response, we were able to find that 85% of our women in supportive housing visited their primary care doctor every 4 months, with an average number of 2 primary care visits during the last 6 months. And also, 89% of our clients in women's housing are prescribed ARVs, and 88% say that they are adherent to their medication, which is pretty high. For those of you who are in AIDS services, you may know that the CDC just put out this significant report that looks at a cascading effect of getting people connected to care. So if X number of people, even who have HIV, even know their status, a certain percentage of that group will even seek treatment. A certain percentage of that number will actually take their medication, and a certain percentage of that number will actually have immunological health improvements. And so the work that we need to do is to improve on those national standards and to improve those numbers, and that's one way to halt the epidemic. So these numbers are significant. Also, since placement, a majority of our clients have experienced improvements in their T-cell counts or have maintained or achieved viral suppression, and that's 56% for the first and 64% of the latter. And then next I'll talk about our work with New York 3 housing. So Harlem United decided to take a different approach to working with this group of 70 clients that we have. These are the clients who are chronically homeless and with diagnosis of HIV or AIDS and or mental illness or substance use. So we all, who's familiar with the ACT model? Okay, so you know it's a model. It's a Medicaid reimbursed model to continue services, almost like field-based services, as if it were to continue the quality of services that's had at in a psychiatric institute. So two of the principles of the ACT team are that clients are pooled, meaning that rather than the traditional case management model of one staff member per 20 to 25 clients, you'll have, let's say, 5 case managers working with all 75 clients, or 70, and that there's an interdisciplinary team approach. Now, Harlem United couldn't have high fidelity to the ACT model, so we tried to do as best as we can, so that's why we're calling it an ACT-like model. So we had a different number of disciplines working with our clients in a pooled strategy. And so the purpose of an ACT model, or the goals, are to decrease the frequency of emergency room visits and hospital stays, to improve health outcomes, to increase connection to medical, psychiatric, and harm reduction services, to reduce incarcerations, and those are the goals. We also added a comparative cost analysis to see if this is actually saving the city and state any money. So in terms of hospitalizations, we found that we compared the period 6 months prior to move-in to the 2 months after placement, and we saw that emergency room visits decreased from 42% to 10%, with the average number of visits going down from 1.81 visits to 1.16 visits. And hospitalizations went down from 38% to 6%. The frequency of hospitalizations went down from 1.6 to 1. However, the average length of stay increased from 9.4 to 14.5. While that might sound not so good, actually it is a good indicator, because what that means is that clients are using hospitals for what they should be using hospitals for, as opposed to one-day visits for primary care. So with those reduced hospitalizations, we saw cost savings. And I'm not going to bore you with all the details, but basically we compared the cost of hospital stays, looked at the reduction, and we saw that there was a cost savings of about $237,000. Similarly, we looked at retention in housing, and we compared it to the federal HUD standards, and we saw that our retention rates after 1 year, 2 years, and 2.5 years were all higher than the national average. And finally, within this program and other programs, this is data on all of our housing programs, we saw that 100% of our clients had a primary care visit in the last 6 months, 93% had a primary care visit every 4 months, 75% had a lab performed every 4 months, and what you see here is just high indicators along our health outcomes. It's important for probably all supportive housing clients, but in particular our clients with HIV and AIDS. Well, now I'll take a look at service needs of housing clients. So this is where I'll talk about how you can use data to help get the best care for your clients and how to relieve staff burnout. If you remember, Harlem United has housing programs. We also have 2 adult day health centers. And oftentimes there's a lot of cross-referral between the 2. And as a chief program officer, I'll often say to my 2 vice presidents, there's one here, Laura of housing and Charlie of day programs, I'll say, refer, refer, refer. We need to increase numbers here. We need to make sure our housing clients are getting good services. And I have all these expectations that the numbers will go up, everyone will get served, so on and so forth. And then what they did was they provided me some data. They would provide good data to say, you know what, your expectations are unrealistic. So when you talked about having a chief program officer who kind of stays in the weeds, I'm one of them, sorry. Sorry, guys. So what they can do is, so for you service providers out there or managers, you can respond to your unrealistic demands of your supervisors by providing data. And this is where data can be your friend. So they can say, look, of all of our housing clients, 25% are already enrolled in the ADHCs. 21% are inappropriate, the yellow and white. 21% are inappropriate. 39% are uninterested, and for various reasons. And so that only leaves 15% who are eligible and who are appropriate and who even might be interested. So that's 15% of 586. You can do the math. It's not, we're not, so I shouldn't expect hundreds and hundreds of referrals. So this is one way to kind of, be more smart about what you're doing. 2, to help relieve the anxiety of your boss. And so for any of you who are supervisors, you know we all have a lot of anxiety. So this is how data can be all of our friends. So I'm less anxious, they have realistic goals, and we're not driving our frontline staff crazy. Rent collection. So rent collections is always a tough thing to manage. So what are some of the common reasons why people don't pay rent? What Harlem United did is we actually took a survey. Of all the clients who didn't pay rent, we asked them, why didn't you pay rent? And so this is what we found. Used money for drugs was the #1 reason. Out of 71 clients, used money for drugs was the #1 reason. Number 2 was they just felt that Harlem United could survive without their money. The third most popular response was that rent is only used when there's an emergency, poor budgeting skills, and so on and so forth. So what we did is, so for example, I think we could all assume poor budgeting skills is a big reason. So if we spend all of our time creating these long, multi-week services of how to create a good budget, how to manage our money, we'd only be impacting 7 people. So maybe that wasn't the way to go. So we did this Pareto diagram. It lines up the reasons in order from highest to lowest, and it draws a graph on the right in terms of percentages. So what you can see, it might be easier to see on this page actually, that you'll see that if you take the first reason, it's 42% of the population, of the group who didn't pay rent, had that reason. So clearly that's the reason we should address. Then if you look at the first 2 combined, that's 65%. If you look at the first 3 combined, that's 76% of the problem. And so technically the Pareto principle is something like 80% of the problems are caused by 20% of the people, or something like that. So maybe it's 76% of the people, whatever. So the idea is that if you can rely on data to understand where your interventions what your interventions should be and how you should apply your energies. And with that, over time, our rent collection rates in housing at Harlem United went from 75.4% in 2007 to 92.9% in 2009, and we actually did this intervention in 2008 and maintained it in 2011 with a 93.5% rent collection rate. So, in summary, so we had some operational efficiencies such as what we did in rent collections, which led to some systematic changes in how we addressed certain issues. It led to programmatic opportunities, as I spoke about before, and that also led to more sustained changes. And all this was done under data. And get it? That's a house. Oh, you can't see. Oh, that's terrible, oh no. But if you look closely, you can see. Can you see the house? Can you see that? Can you see the outline of the house? Okay, good, okay. I would have been really upset if you couldn't see the house. Thank you.